we have a lot that we'd like to get through today, so we'll go ahead and get started. I'm Stephanie Taylor. This is Joy Derwenskus. We're both neuroimmunologists at Vanderbilt and wanted to talk to you all today about managing multiple sclerosis in pregnancy, going from family planning through postpartum. And so, obviously important, our CME code for today is 1284038. And we'll have that up multiple times during the presentation. Here are our
And
disclosures.
I'm sorry, it's not even advancing to the next slides. We still just see the title slide.
Okay. If I click through them this way,
Now we see your disclosure slide.
all right, we're
Yeah,
just going to make it work this way then for us. I apologize, you all.
no problem.
All right. So to kind of get into the talk then, thinking about multiple sclerosis in pregnancy, why is this so important? Why is this something that we like to focus on? MS is the most common neuroinflammatory condition affecting women of childbearing age. In the United States, there's approximately 1 million patients who are diagnosed with MS. There's a disproportionate effect on women who may choose to have pregnancy due to the fact that there is a female predominance with this condition, 3 to 1, female to male. And given the fact that the onset of symptoms is often around 20 or 40 years of age, this is significantly affecting women who are planning for future pregnancy. Up to a third of patients, women who get diagnosed with MS, will choose to become pregnant or become pregnant after their disease has started, after they've been diagnosed. And so this is why it's really important for us to think about what treatment are they going on? Are they going to need any assistance with getting pregnant? What is their MS likely to do during pregnancy? And so that's why we wanted to focus on sort of what to consider in this special population. So thinking about this historically, we've known that there's been an influence on pregnancy and hormonal shifts with MS for quite some time. And historically, women with MS are actually discouraged from getting pregnant. The idea was that anecdotally, neurologists were seeing that there was an increased rate of MS relapse, in particular postpartum. And because of that, women were discouraged from getting pregnant with concerns that there would be more relapse and more disability development. Additionally, when you think back to these patients prior to the advent of some of our more highly effective therapies, we know that patients were more disabled. And so patients may also have chosen not to get pregnant simply from the fact that we didn't have as effective treatments. There's more disability that had built up. And so they may not have been in a situation where pregnancy was a good idea for them. So this PRIM study, the Pregnancy and Multiple Sclerosis study, was really the first large prospective study of just really the natural history of MS in women who had gone through pregnancy. This was a multi-center observational study, including almost 270 pregnancies throughout Europe. The data was published in 1998. And one of the biggest things that we know from this study, and kind of a chart that we refer to a lot, is looking at what is that relapse rate for MS relapses across pregnancy and the postpartum period. So as you can see here, we have the natural history of relapse rate prior to pregnancy divided up into trimesters, and the average pre-pregnancy relapse rate was 0.7 per woman per year with MS. Once we get into pregnancy itself, you can see that over the course of the 3 trimesters of pregnancy, the risk of relapse decreases, most notably decreasing in the 3rd trimester. However, after delivery, and this is what neurologists have seen historically, we see this rebound effect where there's a significant increase in the relapse risk, up to 1.2 per woman per year, associated with that 1st trimester postpartum, and then gradually declining back towards the pre-pregnancy rates. So this was what was ultimately found from this study, giving us a little bit more clarity in terms of the data around what is the actual relapse risk associated. So again, breaking down those numbers, looking at that relapse rate in the year before pregnancy being 0.7, decreasing, not significantly in this study in the 1st and 2nd trimester, then notably decreasing in the 3rd, and then that increased effect again in the first 3 months postpartum. So when you average out all of those numbers and comparing the pre-pregnancy relapse rate and then what is the relapse rate for the entire year of all trimesters of pregnancy and the first trimester postpartum, we actually see that the relapse rate decreases overall when averaging pregnancy and postpartum. So going down to 0.625 compared to a pre-pregnancy rate of zero point 0.7. And so not only do we see averaged out over that year an actual decrease in relapse rate, but they also found that the rate of progression, the rate of disability did not significantly change during the study. So even though there was that increased risk of relapse postpartum, patients overall, when averaged out, did not show that there was increased disability in those who had undergone a pregnancy. And so then looking at some of that risk of disability and even risk of development of MS a little bit further, two additional studies. The first one at the top here, retrospective study of 200 patients where they were looking at disability in pregnancy, and they actually found that in patients who didn't become pregnant, they developed an EDSS, so their disability score of 7, so 7 being wheelchair bound, occurred after only 12.5 years compared to patients who did go through a pregnancy, did not reach a disability in which they were wheelchair bound until 18.6 years. So in this study, they actually saw a decrease in the rate of disability in those who had gone through pregnancy. And then the study at the bottom here was a retrospective study of 108 patients looking at the development of MS and then progressive disability in patients who had MS and went through pregnancy. And what they found was actually women who had never become pregnant had a higher risk of developing MS, and that the rate of progressive disease was actually significantly reduced for women with MS who had gone through pregnancy. So this allowed us to really overall sort of shift our idea about how do we counsel women with MS who want to become pregnant. We do know there's that increased risk of relapse postpartum, and certainly with any relapse, there's the risk of permanent disability, there's the risk of significant changes and effects on their health. But when you average this out overall, there is not a significant increased risk in the year around pregnancy, and we actually see some positive effects on disability development. And so, while that's all very reassuring and things that are really great to tell our patients who want to become pregnant, we wanted to look at, it's important to look as well at what can predict for someone, are they likely to develop a relapse? Are they likely to develop progression? And so several features were found that were most likely to predict who was at risk of those relapses. And the biggest indicator that was identified was MRI activity. So in active MRI, a new lesion or an enhancing lesion in the year prior to pregnancy was found to be the most significant predictor of risk of relapse during pregnancy and after pregnancy. And so they found that there was a significant increase in the relative risk of developing relapse in that first trimester postpartum in patients who had had an active MRI in the year prior to pregnancy. In looking at the PRIM study a little bit more, they found a few different things in addition to that MRI activity that also increased the risk of postpartum relapse. And this included, that increased relapse rate in the pre-pregnancy year, increased relapse rate during pregnancy itself, and then patients who had a higher EDSS, a higher amount of disability at the time of pregnancy onset. So essentially, patients who have been more active in general in their MS, patients who have developed more disability overall, and then specifically patients who have had more active disease in the year before becoming pregnant. So all of this is very important to know in terms of the natural history of MS and was very influential, at the time these studies were coming out before we had some of these highly effective therapies. But it's important for us to now also think, how do we apply this data to patients who are going to be starting on disease-modifying therapy or maybe changing therapy and are wanting to become pregnant in the future? And this landscape has really changed a lot for us now that we have several different types of medications to use, medications that are more highly effective and kind of weighing risks and benefits. So, often we may decide when starting DMT, a disease-modifying therapy, or changing one, we're thinking about how did their MS present initially? Have they tried and failed other medications? Do they have a high rate of disability? Are they at risk of future active disease? In trying to make that determination. We would like to point out that there's a lot of considerations that we should be having as well for patients who are interested in pregnancy in the future and how we determine their disease modifying therapy with that in mind. So we want to be asking patients and thinking about how soon do they want to become pregnant? Do we think there's any risk that they're going to have a difficult time conceiving for some reason? And could that affect the therapy that they're on? Have they had a prior pregnancy since their MS diagnosis or since they had symptoms with MS? And what did that look like? Does that predict for us how a future pregnancy may be expected to behave? And then also even thinking about postpartum considerations, if they become pregnant, would they go right back on the same medication? How quickly is it protective for them in that postpartum period? Do they have strong feelings about breastfeeding? If we're able to support that, all these considerations are something we should be addressing with patients. And so this is a graphic from an excellent review and continuum looking at some of these features with pregnancy and MS and disease-modifying therapies, and essentially recommending that all neurologists who are seeing female patients of childbearing age with, in this referring to neuroinflammatory disorders, MS and NMO, both, with us specifically talking about MS today, and asking about their reproductive plans. If a patient is not planning on pregnancy right now, some of these medications have negative effects if someone were to become pregnant on it unplanned. Some of them have to be suddenly stopped. So it's important that we know, okay, if they're not planning on pregnancy, are they preventing it? Are they aware of ways to do that? And then if they are planning on pregnancy, addressing these different considerations that may lead us to choosing a different disease modifying therapy for them. So, excuse me. These days with MS and disease modifying therapies, there's a lot to consider anyway. There's a lot of medications that are out there. And admittedly, this is very much skimming the surface kind of with it. But I wanted to go over just sort of based on different categories and mechanism of actions, what do we know with some of these medications? When might you consider one in a patient planning on pregnancy? And what risks should we know about with it? So, and these are very broad, kind of within each category. But thinking about interferons and glutamer acetate kind of as some of our first categories, some of our injection medications, older medicines, slightly less effective medicines. These may not be ones that are coming up as often for you right now with patients who are planning on pregnancy, but it's worth it to know that these are considered safe to continue until the time of a positive pregnancy test. There's no known fetotoxicity associated with these two categories of medications. And actually, the FDA has updated guidelines that say that in some patients, the benefits of remaining on their disease-modifying therapy with interferon or glutamer may outweigh any risks associated. So these even can be continued during pregnancy itself. Like I said, this may be less commonly seen in that these are less effective medications. So a patient who has highly active disease and may need to stay on therapy during pregnancy is less likely to be on these medications, but it's worth knowing and kind of considering for a patient. Next category is moving on to some of our oral medications, sort of our moderate efficacy medicines. So think about fumarates. So things like dimethyl fumarate, monomethyl fumarate, all in this category. Again, these are nice options in that they are safe to continue until the time of a positive pregnancy test and have no known fetotoxicity associated either. But one drawback, and I'll point this out with our different medications, is we don't continue this during pregnancy, and unfortunately, these are not medications that have a prolonged protective effect. So what I would recommend considering from that standpoint is, as you saw with that relapse rate, we don't really, during pregnancy, we don't see a decrease really until you get to the second trimester and then most notably the third trimester. So in these medications, though they are safe for someone to be on until they're pregnant, once they are stopped for pregnancy, the patient will lose that protective effect from their modifying therapy sooner than the likely positive hormonal shift that will protect them from pregnancy itself. So just worth that consideration if you have someone that you would feel concerned about them being maybe unprotected for a period of time initially in their pregnancy. Moving on to a category where there are risks associated, and there's a lot of things to consider around pregnancy. So the S1P medications, so all of the ones that end in amod, so fingolimod, siponimod, medications like this. So much like our other ones thus far, these are medications that are safe to continue until a positive pregnancy test, in that there's no increased risk of miscarriage or major birth defects with early pregnancy exposure. However, this is a category of medication that has a risk of rebound relapse when abruptly discontinued. And so, what we mean by that is MS medications that affect lymphocyte trafficking are at risk of causing a more aggressive, more severe relapse when medication is abruptly stopped. The idea being that the immune system is not being modified in a way that's gradually being reintroduced, but rather once you stop the medication, essentially the floodgates are opened, the lymphocytes are available, and we may get this severe inflammatory event. This can occur when suddenly stopping an S1P medication up to 20 weeks after discontinuation, and can be seen up to 25% of patients who stop the medicine. And so this is one that we would have a lot of concerns around a patient who may be pursuing pregnancy in the future being on, because though it is safe for the pregnancy, the baby itself, to continue until a positive pregnancy test, this could put a patient at a much higher risk of relapse and potential disability if this is abruptly discontinued for pregnancy. And this is not a category that could be continued in pregnancy itself. So we would generally recommend transitioning a patient to a different medication if they are currently on S1P medicine and planning for pregnancy. Another oral medication that has some caution around it is teriflunomide. So this is a medication that is considered not compatible with pregnancy, is not safe to be on until the time of a positive pregnancy test, and in fact requires a washout if someone is going to plan for pregnancy or if they become accidentally pregnant. This is associated with fetotoxicity seen in animal studies. For what it's worth, if you were to have a patient who became accidentally pregnant on this medicine, while not recommended by any means or not ideal, human data has not shown the same increased rate of malformation or miscarriage. And loflunomide, an associated medication used for RA, has not shown these effects, but we want our patients to be as safe as possible, and so we would not recommend this one on someone who is potential for becoming pregnant in the future. This is also a unique medicine in that teriflunomide is present in very low levels in semen as well, and so this is a medication where the pregnancy implications apply to both the female patient on this medicine as well as the female partner of a male patient on this medicine, and pregnancy should be prevented in all aspects. Moving on to our last oral category, cladribine. This is a very interesting oral medication around pregnancy in that it is recommended to have a 6-month washout prior to pregnancy. So this is not one that we would have someone take immediately at the time of planning pregnancy. However, because it has a very prolonged protective effect, patients who have been fully treated with 2 cycles of cladribine, they may not require any medication for the next 4 or 5 years. Outcomes of MS during pregnancy are very impressive kind of with this medicine. So the reason for a 6-month washout with this medication is due to the fact that the active metabolite of cladribine is incorporated into the DNA. It's its mechanism, but because of that, they recommend going through at least 2 full cycles of follicle development or sperm development for our female and male patients to have this removed from the system, removed from those precursor cells before pregnancy. So this is one, again, that affects both our male and female patients. However, in patients who are more than 6 months out from their cladribine and interested in pursuing pregnancy, in very small studies that have been done, admittedly, there have actually been no reports of relapse in either pregnancy or postpartum in patients who have gone through full treatment cycles with cladribine. So this can be a really good option for someone if they're planning on pregnancy in the next 2 to 3 years, but not right now. And so to have time to be fully treated before that washout period. And so then moving to our more highly effective categories of medications. So looking at some of our IV medicines like natalizumab. So this is a very interesting one with a lot of different factors around pregnancy. So it is a medication that's considered safe to continue until the time of a positive pregnancy test. But again, this is a medication that affects lymphocyte trafficking. And so we do have worry about the risk of rebound relapse when abruptly discontinued for pregnancy. So much like the S1P medications, we do see this increased relapse rate seen in natalizumab patients, up to 40% of patients when this medication is abruptly discontinued. And this rebound effect is often seen in the first 12 weeks after discontinuation. So if you have a patient where they would be stopping this medication for pregnancy, we do have concerns around that risk of relapse when they are in the initial time of pregnancy and they're not yet protected from hormonal shifts. However, if you have a patient who's interested in continuing medication during pregnancy or who's had very highly aggressive disease in the past, natalizumab is an interesting one in that we have significant safety data that actually supports continued use during pregnancy. And now, admittedly, this is off-label use. This is worth having a very detailed risk-benefit conversation with the patient. But in some pretty extensive reviews, there have been no significant risks to the pregnancy associated with patients who were treated up until 30 weeks. There's some reports of small lower birth weights, small for gestational age, in patients on natalizumab, but this is also commonly reported in MS overall. And if patients are treated after 30 weeks with natalizumab, this has only been associated with a mild and self-reversible anemia and thrombocytopenia that has not been reported to have any complications associated with it within babies themselves. And if someone warrants therapy during pregnancy, there are significant benefits in addition to safety with continuing this medication. So patients who were treated with natalizumab through the first trimester of pregnancy had only a 3.6% risk of relapse compared to 38.5% risk of relapse in those who abruptly discontinued their tisabrine at the time of a positive pregnancy test. So a lot to consider from that aspect. Um, and then moving on to our last category of MS disease modifying therapies is our anti-CD20 medications. So, of course, there are other ones in this category as well, but think about ocrelizumab, ofatumumab. And what we know with anti-CD20s is there is a lot of safety around these medications in pregnancy. So in general, the recommendations with ocrelizumab are to wait 2 to 3 months after the last infusion to try to conceive. This is generally recommended by MS specialists who focus in women's health and pregnancy in MS. So I will just say that with the half-life of medicine, this is actually cleared from the body before the full development of the placenta, which is how the pregnancy would be exposed to these monoclonal antibodies is by crossing the placenta. So realistically, your patients, if they were to become pregnant unplanned shortly after an infusion, very highly likely that they would have good outcomes nonetheless. And then ofatumumab, our injection anti-CD20, is considered safe to continue every month until the time of a positive pregnancy test. So there's no waiting period associated with this medication. And in addition to the safety, it's worth it to point out the positive effects of these medications. So as we all know with anti-CD20 medicines, though we dose the IV treatments every 6 months, though ofatumumab is an injection every month, we do know that if we were to check labs on patients, we see a persistent immunosuppression generally much longer than 6 months, in some patients up to 8, 9 months time. And so this allows for patients to be well protected in the early part of their pregnancy before those positive hormonal shifts. And so this can really support excellent outcomes for patients when they're on these medications and planning pregnancy. So I apologize, but that is a lot in terms of the different medications. It's, looking at these MS medicines, there's a lot to consider overall now and a lot to consider with pregnancy. So just to give you a slide of some of the snapshots with this, several medications being safe to continue until the time of positive pregnancy test. What do we worry about that rebound effect? What can we not use in pregnancy? And just considerations to have for your patients. This gets into the idea of when might you choose a different medication for someone. But I want to make sure we have time for everything today, so I'll just move quickly. But just kind of considering, are you going to have a patient who may need to take longer to get pregnant? So you don't want them to be on a washout medication, something they have to be off of for a period of time while they're trying to conceive if we think it may take longer. If they've had more aggressive disease in the past, can we get them on a medication that provides more prolonged protective effect, like an anti-CD20, or a medication that's safer to continue during pregnancy, like natalizumab? So just considering those sort of options, as well as timing of pregnancy. Are they newly diagnosed and hoping to get pregnant right away because they're in their late 30s and that's their plan for right now? Or do we have time to let their medication become effective before becoming pregnant? So within this, I'd just like to put a caveat out there of we would recommend, as neurologists, we're often not talking about how to conceive, how to successfully become pregnant with our patients. But I think in this population where there's so much impact on their neurologic diagnosis, it makes sense to review this. So talking to patients about tracking their menstrual cycle, how to use ovulation test strips to find the surge in luteinizing hormone to be more likely to conceive. I think it's important that we address these, in particular with our patient population being so heavily female and potentially planning for pregnancy. And then my last note before moving to Dr. Winskus and what happens in pregnancy itself, thinking about what if there's any risk of infertility or what is the association with fertility in MS. So it's not clearly known if MS affects fertility. We do know there's a higher rate of infertility diagnosis, but we also know patients with MS tend to try for pregnancy later in life, sometimes waiting for disease stability before that happens. So it's unknown if that is age-related or related to the condition. Overall, there are lower rates of fertility treatment seen in MS, potentially due to patients being more cautious about pregnancy. But if there is any concern for infertility, we do recommend early referral to OB/GYN to minimize the amount of time someone may be off medication to get them evaluated sooner. And then if they do go through fertility treatments, it's worth it to know that there are reports of increased relapse rates in patients who go through fertility treatments. However, these are also patients who are generally being more cautious and may be off of medications entirely or on low efficacy, older, safer medications when they're going through this.
All right. Sorry, we're gonna swap here. Anyway, so here's the CMEA code again for you all. So I'm going to talk about kind of what happens during pregnancy. Why do we see this reduction in relapse? And so basically during pregnancy, the whole point is the woman's body wants to protect the fetus, right? So there is a kind of dampening of the immune response and the presence and increase over time of these kind of protective hormones, which again, really the point is to kind of protect the fetus. And so there are these influences that will come from the placenta, the mother, the fetus, and really kind of regulating or creating this anti-inflammatory response, which is good for people with MS. So over time, you see this notable increase in estrogens, progesterones, activated vitamin D from both the mother and the placenta, and this will lead to a reduction in autoimmunity. And with this, they see a reduction in the T cells and this shift from the Th1 to the Th2. And this is what our medicines do in MS. Some of them really focus on this shifting from this pro-inflammatory Th1 cell to the anti-inflammatory Th2. So, we don't see the effect right away because it takes time for these hormones to kind of build. So it's not an immediate protective effect on reducing the risk for relapse, but later in pregnancy. So as Dr. Taylor mentioned, and this is just a pictorial graph of showing we have the placenta, the mom, and the fetus, and basically the placenta here is going to be putting out these hormones and anti-inflammatory cytokines and cause this shift from Th1 to Th2, which is good, and kind of what they'll say remission, but really an anti-inflammatory response here. So, all right, care during pregnancy. Generally women do well during pregnancy, and to be honest, they feel well. Their symptoms often are better it's not uncommon for us to hear women say, I wish I could be pregnant all the time because I felt so great during my pregnancy. And then, Dr. Taylor already mentioned this, that we have to just, not everyone will do well. There will be some people who have a relapse, whether that's just people who have active disease or if it's a rebound effect. I think it's still very important that as neurologists, we're going to treat patients clinically, really approach them in terms of, what's the impact of function disability, whether it's a relapse or whether it's the symptoms they're having. And if there's any concern, we can do an MRI scan. It is not recommended that women who are pregnant get gadolinium. So you can do it without GAD, and if it's an established patient, obviously compare to see if there's any new lesions compared to the prior scan. This came up recently. I was just talking with the hospitalist. They had a different case of somebody who had a mass, and they were trying to figure, they really felt like they had to give GAD. It was a patient who was 21 weeks pregnant, so they ultimately did give GAD. But I think it just really needs to be this risk-benefit discussion, because that, is it going to impact what you do for that patient? And I'll talk a little bit more on a different slide about treating relapse, that we can use steroids. So what is a relapse? So a relapse is, by definition, I'm sure you're all familiar with this, but this is our classic definition. So any new or worsening neurologic symptoms that have to last for at least 24 hours and in the absence of fever or infection. And so whatever that symptom might be, it could be fatigue or cognition, it could be weakness, walking problems, vision loss, whatever the symptom is. So when do we decide to treat a relapse? Again, I think the most important thing is approaching that patient like, is it impacting your function? And if it is, then I likely would at least have this discussion about potentially treating them. For me, if they're having more mild symptoms or definitely probably sensory symptoms, I'm not as quick to jump to treat those, only because I think in my clinical experience, treating with steroids doesn't necessarily make those sensory symptoms go away, or at least not that quickly go away. So I'm not sure the impact is much, but I do think that we need to think about, are they really having a relapse, or is it a pseudo-relapse or pseudo-exacerbation or recrudescence of old symptoms? So classically, we think of kind of like fever, infection, UTI, right, are really common causes for bringing out symptoms. So this like recrudescence. But I think in pregnant women, we have to think about, have they been experiencing significant nausea and vomiting? Are they really having sleeping issues? So significant insomnia, fatigue, stress, all those things really can lend to kind of bringing out symptoms in a patient with MS. It could bring out old symptoms. So we can treat with steroids for relapse. Short courses of glucocorticoids are considered safe. We do prefer methylprednisolone, prednisone, or prednisolone, because these are inactivated by the placenta 11 beta hydroxysteroid dehydrogenase. So they get broken down and they don't enter into the fetal circulation, as compared with dexamethasone, which the majority of it actually does cross the placenta and enter into the fetal circulation unmetabolized. So, I think dexamethasone really should not be used, but using typical methylprednisolone or prednisone. Now, there were concerns earlier, of cleft palate with early use, early exposure to steroids. This really hasn't actually panned out, but with kind of further studies. But in general, I think, like a lot of things in pregnancy, people will say to avoid during the first 10 weeks. This came up recently for an MRI for a patient at Dr. Taylor's. And I think just theoretically, people have this concern because of organogenesis up until that point. And so, but I think if you have a patient who's having a bad relapse and you need to treat them and they're 8 weeks pregnant, I would, obviously have a discussion and interact with their OB-GYN and discussion with the patient and come to that decision of if you think that's worth potential increased risk. So, and then repeated exposure to high dose steroids during the second and third trimesters has been associated with some issues, hypertension, preeclampsia, either intrauterine growth restriction, and low birth weight. When they looked at, this is looking at just even in non-MS patients. So plasma exchange, it is not commonly used during pregnancy, but I do think it rarely could come up. This is just looking at a meta-analysis of 279 studies. It was it's not just autoimmune. I kind of took that section out of there, but it was published in 2020. And basically, plasma exchange appears to be safe when compared to doing this in non-pregnant patients. And so obviously we have an MS patient having a bad relapse that you give steroids and they're not getting better, or NMO. I think if you have somebody who's deteriorating, not unreasonable. Now, obviously you want the people who are doing the plasma exchange to have some experience and feel comfortable with that, because there are some potential special considerations, but it is something that could be utilized. All right, I'm going to shift gears a little bit. We'll go quickly through symptomatic treatment of MS. This is just a slide from a paper published from a group from Great Britain, and so you can tell because there's some drugs in here that we don't have approved in the United States. But anyways, this is just showing some of the common symptoms: pain, depression, fatigue, urinary issues with UTIs, walking problems, spasticity, and the variety of medicines that we can use. And like in all of neurology, I think we want to think, okay, if they're having a problem, is there one drug that we could use? So maybe there's one drug that might treat their mood and their pain, or their pain and their spasticity. So I think really trying to think of this combined effect of using a medication. Symptomatic treatment, I feel symptomatic, if I was the person, gets slighted. And whether that's during pregnancy or not, I mean, picking a disease-modifying treatment is always such a big part of managing a patient, but so is treating their symptoms, because that's what's going to make them feel better potentially. And so it's a really important aspect of caring patients for MS, but also we need to think about it as we're counseling women for pregnancy. The problem is there really is just not much data. And I put in there the caveat that these, most of these symptomatic treatments are off-label use. They're not FDA approved for these indications, and we don't have pregnancy, like they're not approved for use during pregnancy. So, and I think overall women just have this mindset, like, I have to get off all my medicine before I get pregnant, or when I get pregnant. And I don't know that that's necessarily the case. I mean, obviously we have to kind of weigh the impact to the patient. And so these are just some general principles from this paper. We have to weigh the individual risk of stopping or switching to the potential harm of that pregnant person compared to the potential harm to the unborn baby related to a particular medication. And I think really having, they talk about multi-professional, team approach, whether that's working with a psychiatrist, working with the OB-GYN, working with MFM, whoever that is, but a team approach to kind of figuring out what's best. Always want to have the lowest dose possible for the shortest period of time. And, just the fewest number of medications is probably best to ensure the safety for both the mom and the baby. And it really should be, in this paper, they say you should allow the patient to make a final decision. I would say it's a joint decision-making between, you and the patient, but really have this kind of risk-benefit discussion. And but taking into account how the patient, how much it's impacting their life. So now I'm going to go over specific symptoms quickly. MS symptom, so like depression. I think depression is a big one. I mean, I just don't think it's reasonable if someone's had significant depression before they were going to get, before they got pregnant, or when they're planning for a pregnancy, that we should treat that. And overall, I think SSRIs are perfectly fine. There is a potential low risk for cardiovascular birth defects, as well as this condition in the newborn, persistent pulmonary hypertension of the newborn, which is about 1%. So the risk is quite low. So again, interacting with a mental health provider, and I think really kind of thinking about maybe just getting them to a therapist might be helpful. There's a newer review paper that came out this year, and these were their specific. So sertraline looks to be maybe used during pregnancy. There are still some potential risks. Duloxetine should be used with caution. There was an increased risk of postpartum hemorrhage and then some issues with the neonate potentially. But again, I think most OB-GYNs are perfectly fine with continuing an SSRI. But okay, so spasticity, probably the one that people would think about using would be baclofen. There are, it should be used with caution. There are still some increased risk for congenital malformations, but we don't have great data. And you have to think about potential withdrawal symptoms in the neonate if they're taking it throughout their pregnancy. Really don't have great data for tizanidine. Cyclobenzaprine, I use it a lot for migraine patients who are pregnant. I think it is something that can be considered. I'm not a big fan of using benzos, but if you had somebody potentially having significant spasticity, it could be used for low doses for short intervals. intramuscular Botox, they talk about using with caution. Again, we use this in migraine patients who are pregnant. There's some data for that. So, but I think thinking about adjunctive things for a lot of these patients, whether it's spasticity or walking problems, would be physical therapy. So really get them to work with PT, stretching, all very important. Gait issues, we use this medicine called famotidine or formanoparidine. Could be considered, but data is really lacking. There are some potential concerns given animal data. Again, I think working with physical therapy would be helpful. It is possible, potentially, I guess, to just reduce and only give them a dose once a day instead of twice a day, but it just depends upon the individual. Pain, gabapentin is favored over pregabalin. Patients should be on folic acid with either of these, is what they discussed in that paper. There is a potential risk for major malformation on pregabalin, so that's why I think people would favor. We just don't have great data for gabapentin, but I think probably considered to be safer. And amitriptyline, nortriptyline look to be safe with the limited data we have. Carbamazepine should be avoided due to congenital malformations. And then I already kind of talked about this duloxetine, tramadol. I don't use so much, but is considered safe. And then again, these non-pharmacologic things. So again, physical therapy, massage, maybe acupuncture, hot and cold packs, TENS units, whatever. But other things that could be utilized. Fatigue and urinary symptoms. I think I always kind of chuckle when I'm asking patients about these who are pregnant, because I'm like, what are we going to do? But I mean, because it's such a common thing with just being pregnant too. So, but in general, amantadine should be discontinued. Modafinil potentially could be used. There are some potential risks with it. In general, I probably have tended not to use these medicines for fatigue. And encourage making sure they're getting as good of sleep as they can, getting some exercise, so the usual other adjunctive things they could do. Bladder issues. There's great, we don't have great data for oxybutynin or sildenafil, but again, kind of looking at the individual person, how much of the bladder symptoms impacting their function. Another thing that I think we don't consider as much as we should is pelvic floor therapy, whether that's during pregnancy or in the postpartum period. And then my last slide is just talking about delivery and birth outcomes. I think historically women were told, well, a couple of things. I think they often have been told they're a high-risk pregnancy. You're not a high-risk pregnancy. And there was always this concern, like, my doctor, I mean, fortunately, we don't hear it very much anymore, but my doctor told me I can't have an epidural because it might worsen my MS. That's, so there was this theoretical concern, but it really never panned out that there would be an increased risk of exacerbation with epidural spinal anesthesia. So, and then basically I just tell patients, like, talk to your OB, basically tell them that I said whatever they would do for any other patient, like, that is fine in terms of delivery. There are studies showing that there's a higher rate of planned C-sections in MS patients. And I think obviously you have to consider those patients who are having a lot of weakness or spasticity in both their legs, likely have weakness of the pelvic floor. And so what they have seen is that the assisted delivery with either forceps or vacuum extractor is more frequent in patients with MS. In terms of birth outcomes, patients may be obviously concerned about this, but really there's been no difference in APGAR scores, perinatal mortality, birth defects. There was some thought that if babies were smaller, but that's really not kind of held up to be the case. So, and then we'll shift back to Dr. Taylor here, sorry. For the postpartum period.
Yes, bear with us. That's our last change for this. So looking more then at the postpartum period, so after going through all of this pregnancy planning, after the outcomes for pregnancy itself, after the woman delivers, that protective influence from the placenta and the fetus is lost, and we're returning back to a pro-inflammatory immune state. So there is this shift back towards the Th1 cells away from the anti-inflammatory Th2 cells. So this is what leads to that increased relapse rate postpartum. And so then just to illustrate that effect, as we lose the input from the fetus and from the placenta, and now additionally having input from prolactin from the postpartum woman, this is all shifting back towards that pro-inflammatory state, and this is what is increasing that risk of relapse. So we do see that in up to 30% of patients, there may be a clinical relapse experienced in that first trimester postpartum, those first 3 months postpartum. And even if MRIs are done after that first trimester postpartum in an asymptomatic patient, frequently there may be changes found nonetheless. So in almost a third of surveillance MRIs, new lesions are found after that 1 year of pregnancy and first 3 months postpartum, even in patients who did not have any new symptoms. So it's worth it to get a new MRI done at that period to really establish a new baseline. So things that we want to consider for patients in the postpartum period is getting that surveillance MRI. Like I said, we in particular tend to recommend about 3 months after delivery because that'll capture that highest risk period for new lesions, including asymptomatic ones. We want to think about how are we preventing that risk of relapse when those hormonal shifts suddenly happen. And so that can be with resuming disease modifying therapy right away, and especially thinking about those disease modifying therapies that have a quick time to onset. I have listed here treat with monthly pulse steroids because this is something that was commonly thought of in the past. And so this may be something that you've considered or you've had a patient that had done for them before. More recent data has shown that this does not really have the protective effect that we would like it to have for patients. So this may be less recommended now than it was previously. And then, like Dr. Derwenskus was saying, with the symptoms during pregnancy, we want to think about how those symptoms are impacting the patient postpartum as well. So where's the overlap between common postpartum symptoms and MS symptoms? So think about fatigue, mobility issues, bladder dysfunction, mood disorders, and making sure that we're addressing kind of all avenues of that symptomatic care. And then I think something that's very important to consider with these patients that was often dismissed as not a possibility historically was the option for breastfeeding if a patient kind of so desires. So much like pregnancy itself, historically, women with MS were discouraged from breastfeeding due to this thought that medications needed to be started sooner rather than later. However, in more recent studies looking at exclusive breastfeeding, so this is frequent breastfeeding to a sufficient level that there's not any supplementation with formula, that in these patients, there's actually a reduction in postpartum relapse up to 43%, and its protective effect is seen through those first 3 trimesters postpartum. So I think that we can really support women who want to pursue this option, knowing that almost half a reduction in that normal postpartum relapse rate. And we believe this is because of the hormonal effects of lactational amenorrhea that mimic that hormonal state that you see during pregnancy. So again, just a figure kind of depicting how some of those changes that occur with lactation are causing that same shift away from the Th1 autoimmune kind of presentation back towards an anti-inflammatory presentation for patients. And so the last comment I'll make in terms of breastfeeding and kind of their postpartum care is, in some patients, they may also have the question of, well, I'd really love to breastfeed. This is really important to me, but I'd also like to be protective for myself and go back on my medication. Can I do that? For most of our MS medicines, they're restarted after breastfeeding is discontinued. However, there are some medicines that we have reasonable safety data for that we can certainly have that conversation with patients. So often I'll recommend that we wait until at least 2 weeks postpartum to get through the period of more concentrated milk with the colostrum and transitional milk. But after that time, there are medications we can consider like natalizumab, anti-CD20 medications, interferons, or glatiramer acetate that do have significant safety data associated with them. And so certainly that is, again, a risk-benefit conversation to have with the patient and very patient-specific, kind of when do we consider this. So we'd just like to point out, that Dr. Derwenskus and I are both more than happy to consult on a patient who's planning pregnancy, during pregnancy, and the postpartum period, any sort of considerations around this. And Dr. Derwenskus is actually our director of the Vanderbilt Women's Neurology Clinic overall. So we do have these consultations even with outside of neuroimmunology. And I'll let her speak a little bit towards what we offer.
Yeah, so we recently just kind of formally established this. I came from Northwestern. We had a program there as well, but so we do have a formal clinic. There are a bunch, basically all the subspecialties have some providers that have an interest in women's health, and so I listed the people there. Currently, we're only doing internal referrals because we're trying to just kind of get this off the ground and but we would be more than happy to, as Dr. Taylor was mentioning, if you have any patients, sorry, and yeah, oh, it's the next slide. But anyways, if you have any patients, feel free. We have I have a slide with our emails on it. But so whether that's, you know, epilepsy or an MS or sleep, if you have a menopause patient or something, we're happy to try to see them. And then there's also a big women's heart group here, and we are going to be doing a joint symposium with them. So I just putting this out there, save the date if anybody wants to come to Nashville for a weekend next March 21st. We'll be doing kind of a joint cardiology, neurology symposium with some breakout sessions and some joint sessions. I think it's going to be really exciting. We hope to be a very great program. So, and then we just included our emails here. So if you have any questions or any referrals, feel free. I mean, I'm happy to see for either of us for MS, but if you have anyone just overall in neurology that you feel like needs to be seen for a women's health appointment, feel free to reach out to me. And we are, Dr. Taylor and I both have licenses in the state of Kentucky, so we can do teleconsults. So, and these kind of visits are, you know, we're not necessarily examining. It's a lot of consult. It's just a lot of discussion. So they don't need to come to clinic necessarily. So, and here's the CME code again for everyone. Hopefully you've gotten that down. And yeah, so thank you very much. And we're happy to take any questions you may have.
I think there could be a bit of whiplash after the amount of medications and detail that Dr. Derwenskus and I tend to go through with this. So, you know, truly, we share those emails, or, you know, feel free to reach out to anyone who's connected with us. We would really be more than happy to talk about specific situations, do consults on your patients if there's kind of that extra management required during that planning period or during pregnancy itself.
Or in other situations, people want to do IVF or do egg, you know, cryopreservation. So egg preservation. I mean, we've seen consults for those as well. So,
can you hear me?
Yes.
Hi, this is Martin Brown. Thank you for that very as a great review, very comprehensive and very informative. How much do you discuss? There is a baseline frequency of malformations in people who are not treated for anything, and about how much do you kind of discuss that, just to sort of make sure that people know this happens even without MS and even without MS drug?
So I'll say we're with a lot of these consults, we do talk about that in terms of looking at the safety with these medications. So, you know, we actually have educational information for our patients on each of the MS medications, each of the categories, and have separated out within it. These are the baseline rates seen in women without any diagnosis, not on any medication, or, you know, just general population. This is the rate of miscarriage. This is the rate of minor and major malformations. And that's how that compares to patients who are on these medicines. So we do like to give them both aspects of that data so that they do understand that, you know, even the ones we say there's safety associated, there are, you know, just kind of these baseline risks of negative outcomes.
Yeah, and I think that's an excellent point, right? Because people are so worried it's going to be the medicine, but there is just this innate risk for whether it's miscarriage or congenital malformations that is a baseline rate potential. Yeah. Well, if nothing further, thank you so much for having us virtually, and appreciate everyone attending, and take care. Have a good weekend.
Thank you all.
Bye. Thank you.
Bye now.